On behalf of the Brazilian Society of Functional Neurosurgery, I'd like to thank everybody for attending our webinar. The audience has reached a considerable number of people all around the world. That's the reason why we are using English as the main language for all lectures. Our topic today is epilepsy, and Dr. Paulo will present the speakers and panelists. So go on, Paulo.
Thank you, Antonio. Welcome to everyone. Today's topic certainly interests us all because despite advances in the modern epilepsy drug therapy, approximately 30% of adults with epilepsy remain refractory to medicine treatment. Some of these patients are candidates for resective surgery, but for those who are not surgical candidates or who continue to have seizures after surgery, neuromodulation may offer a viable therapeutic option. Today, we'll talk about the effectiveness and safety of deep brain stimulation to improve seizure control outcomes and sustaining reduction in the frequency and severity of seizures in a very refractory patient population. We have selected an important group formed by neurosurgical professors of important hospitals for epilepsy surgeries in Brazil. The panelists invited today are professors. Professor Tatiana von Herting is a neurosurgeon from Hospital Universitário Cajuru, Hospital Marcelino Champagnat, Hospital Pequeno Príncipe, and Hospital Vila BR, Curitiba, Brazil. Professor Ricardo Centeno is a professor of neurosurgery, Department of Neurology and Neurosurgery, Federal University of São Paulo, Brazil. And the Professor Arthur Cuquiert is a neurosurgeon, director of the Cuquiert Clinic, Neurology and Neurosurgery, São Paulo, Brazil. Our speaker today is a Professor Caio Matias, graduated and postgraduated from University of São Paulo, campus Ribeirão Preto, fellow in the functional neurosurgery in the department of the Cleveland Clinic, and currently postdoctoral researcher in the Thomas Jefferson University, Philadelphia, United States. Many thanks to everyone for accepting the invitation from the Brazilian Society of Functional Neurosurgery. Professor Matias, the stage is yours.
Okay. Thank you, Paulo. I hope everyone is seeing the first slide normally. Thank you, Antonio. Thank you, Paulo, for the invitation. It's always a pleasure to meet our friends from Brazil. Even we have to do it virtually right now because of this pandemics, but it's always a good opportunity to meet the friends, to talk to them, and especially when we're going to talk about epilepsy, that's something I'm very fond of, the treatment of refractory epilepsy. So I have no disclosures related to this talk. My idea today is to talk about especially ANT DBS, talk a little bit about targeting, some pitfalls in the treatment, the deep brain stimulation of epilepsy, and also talk about other possible targets. Paulo has already started this conversation about the importance of neuromodulation or the treatment of refractory epilepsy. As he mentioned, not all patients that are refractory to medication are candidates for resective surgery, but fortunately, today we're able to offer additional options such as deep brain stimulation for those patients. DBS for epilepsy is still a field of ongoing research. We still need to understand better the mechanisms of action for stimulating the brain and treating epilepsy. Some hypotheses say that stimulation may disrupt a pathological network that those patients might have. Some studies have shown that when you apply high frequency stimulation, you induce cortical desynchronization, and that will protect the brain against seizures. It will stop or prevent seizures. But other studies also have shown that when you apply rhythm stimulation, you can help synchronize the thalamocortical networks, and that would also prevent the spread from one or two or a few foci to the rest of the brain through the thalamus. So what are the targets for neuromodulation in epilepsy? The most famous or the most common one is the anterior nucleus of the thalamus, but we have other options like the centromedian nucleus. I'm going to talk a little bit about STN, substantia nigra as a target. Of course, the hippocampus, although the hippocampus is here, at least here in the US, is much more common used as a target for RNS, for responsive neurostimulation. There are some papers from a few decades ago talking about cerebellar stimulation for treatment of epilepsy. And also we have always to mention VNS as an option for neuromodulation, although it's extracranial and not deep brain stimulation per se. So starting with the anterior nucleus of the thalamus, or the ANT, as suggested by the name, it's located in the anterior and also the superior part of the thalamus. It's a very important part of the PAPE circuit. It's connected with the hippocampus and the mammillary bodies through the MTT, which is the mammillothalamic tract. And then it has efferent connections with the cingulate, which then spread to the superior frontal gyrus mainly. So having that in mind, in the 70s and 80s, Upton and Cooper, they decided to study the anterior nucleus as a target for stimulation for the treatment of drug-resistant epilepsy. So they did a pilot study in 6 patients between 76 and 86. Those patients had intractable seizures. So they did chronic stimulation of the ANT for a brief period. And the results found that 4 of those 6 patients had what they called marked improvement in seizures. Okay. They also had improvement in psychiatric symptoms. They found that the PET scan was normalized, the metabolism, and 5 of those 6 patients had improvement in behavior. So very good results, which led to other groups to try also in different pilot studies. As you can see, most of those studies had at least 50% seizure reduction. Although the number was small, the outcome was good. And having that in mind, they decided to do a larger trial, which was the SUNTED trial, the stimulation of the ANT for epilepsy. In that trial, they selected adult patients between 18 and 65. The patients had to be, of course, drug resistant to epilepsy, and they had to be not a candidate for potential resective surgery. Initially, there was a blinded phase for 3 months after a 1-month period of washout from the effects of the surgery. And there was a difference. Apparently, the active group, which had the DBS turned on, had a better outcome for the blinded phase. And after that, there was an open label phase, which also showed improvement, a good outcome, with a median, an average of at least 56% seizure reduction in 81 patients. They kept on following those patients, and then in 2015, they published the long-term results of those patients. And what they found was very interesting. After 1 year of deep brain stimulation for epilepsy, the seizure reduction rate was about 41%. But after 5 years, the rate was much higher, almost 70%. Okay, and that we can see here in this chart again. So over time, the seizure reduction increases. So that might be an effect of stimulation, or perhaps that might be an effect of stimulation and better medication adjustment of those patients. So many of those patients were still having seizures. They had reduction, but how much reduction is significant? So Bob Fisher said once that if you assume an average of 60 to 20 seizures, and you implant 100 patients like they did on the trial, over a course of 5 years, a period of 5 years, if you have at least 40% seizure reduction, in 5 years, you'll be preventing almost 50,000 additional seizures. And we have to think about what those 50,000 seizures could cause to those patients, including associated injuries and SUDEP. Even after a few years of that trial, there are still many questions. We're still not sure what's the best or the optimal patient to be selected, what's the location within the ANT. Of course, there are risks as every STERTEX procedure. We've been using the same parameters. It's not like essential tremor or DBS for PD, where you can play with the parameters. Of course, you can play with the parameters, but usually you have a fixed frequency and pulse width, but you change the amplitude. So regarding the targeting, when they did the Santa trial, they mainly were using a mixture between indirect targeting, using those coordinates, and a mixture of trying to see that bump on the sagittal above the thalamus. But the thalamus is not the same between all those patients. There's a high degree of anatomical variability between patients. There's a very interesting paper from the Finnish group that was published in 2015. In this study, they segmented out the ANT in, I think, 8 patients or 10 patients. And the figure on the right is showing how much variability you can find between those 8 patients. In red, you see the areas where you have overlap, total overlap between those patients, and in dark blue, where there was no overlap. So as you can see, if we use indirect targeting, we're going to be targeting different positions between different patients. So where's the hotspot for targeting or for stimulation inside ANT? There's a recent paper from this year, from May, which they used as a landmark the junction between MTT and the mammillothalamic tract and the ANT. And what they did, they identified the active contact. They created the VTA around that contact, which is the volume of tissue activated based on the stimulation parameters. And they measured the distance between that VTA and the junction between MTT and ANT. And they found that the responders, the distance between the active contact and the junction was significantly smaller on the responders versus the non-responders. And if you look at the previous studies, you can see that you can see that the junction or close to the junction apparently is the sweet spot or the hot spot within the ANT. Here's a better view showing the previous studies where they found the hot spot. So that brings us to the direct targeting of ANT. Right now we have different imaging protocols as we had for the Sunset trial. We can see very clearly MTT, the medullary lamina, using a steer sequence, using MP-RAGE, or there's a sequence called F-Gator from Siemens, which also helps visualize the MTT. Here at Thomas Jefferson, we use a regular proton density with a short stack with 1 millimeter distance between slices, and we can also see it very clearly MTT. Here's some examples showing MTT on the axial, on the coronal, and on the sagittal. So to target ANT for implantation, you can find the mammillary body, you can follow it up to the mammillothalamic tract, and then when it reaches the intermedullary lamina, that's probably the intended area to be targeted. You can see here on a 3D figure the same structures. You can see the hippocampus. You can see in pink the mammillothalamic tract going up all the way to the ANT. Usually to get to have a nice trajectory going through the ANT, we have to go through the ventricle. But there are some limitations. You have surface veins, you have the callosal marginal branches, and you have the thalamus-striate veins. As you can see here in this 3D figure, here's the thalamus-striate vein, and the window sometimes is not wide enough. So sometimes you don't have much option to avoid all those vascular structures I mentioned earlier. So which one is the best approach? Transventricular or extraventricular trajectory? The same group from Finland, they analyzed both type of trajectories, transventricular and extraventricular, and they wanted to know if there was at least one contact inside the ANT on one side or both sides. And they found that when you go transventricular, the chances of having at least one in one ANT or both sides, at least one contact, are much higher if you go transventricular. As I said before, there are some limitations because of the thalamus-striate vein. And here I'm going to show an example of one of our cases here. As you can see, the thalamus-striate vein had a loop, and that was the space we had, about 1.5, 1.6 millimeters of space to play around to find a nice entry point. So our major concern was to, when enter into the ANT with the cannula, we were concerned about hitting that vessel. So we decided to insert the cannula all the way just as close as possible adjacent to the ependema, and then insert only the electrode, which has 1.27 millimeters. We tried, that was our plan, but when we did, we used the O-arm to check the implantation, but when we did the first X-ray, we could see that the contacts were deviating medially. So we did an O-arm spin to check the position, and we confirmed that it was off. It was more medial and more anterior. So we did a second pass, now with the cannula all the way in to target, to the junction between MTT and the intermedullary lamina. And apparently now we had a good position. But when we removed the cannula, we could see that probably the contacts were, the electrode was going back to the first track. So the second pass with the cannula, and now an overlay between the second pass with and without the cannula. As you can see, it was deviating again. And the first pass overlaid on the second pass. So we decided to stop the procedure for this case, and we came back a few weeks later, now doing a posterior approach. And that was our plan. Again, we needed to go through the ventricle. But then using this trajectory, we were able to deviate from that thalamus striate vein. And we did that with the patient in the lateral position. So we could implant both electrodes. We used the robot, we used the O-arm, and that was the position we chose. And we were able to find at this time, a nice final position for both electrodes. A few months later, we had a similar case. The limitation was not the thalamus striate vein. The limitation was that the patient had multiple previous surgeries and had multiple titanium meshes exactly where the endpoints could be on the frontal, through the frontal lobes. So we decided to do for her the same posterior trajectory. Now, there's a problem with this trajectory. If you're, depending on the angle you have when you're trying to enter the thalamus using the posterior trajectory, you might either push down the thalamus or you might skive the thalamus. And that's what happened to this patient. When we did the first pass, as you can see here, that's the trajectory in red and yellow. And you can see the overlay with the O-arm spin showing that the lead was deviating superiorly. Interesting, when we checked the impedances, they were fine. They were not showing CSF, they were showing your inside parenchyma. So we decided to leave it there, having in mind that maybe it was not the best position, but when we did an MRI, we could see that the position was acceptable, and we were able to program the patient and produce benefits from stimulation. If you want to avoid skiving or moving the thalamus on the posterior trajectory, you have to find an extraventricular trajectory. However, if the patient has large ventricles, that's going to be probably impossible. But for some patients, you can find it. Now, one of the problems with the ventricular or the transventricular approach is brain shift. If you lose CSF, probably the brain will change its position. So there are several papers talking about that. I'm gonna just show this one here. It wasn't exactly for DBS for epilepsy, it was for movement disorders, but they compared two groups of patients. They had implanted DBS for the brain stimulation, and they found that when you had transventricular trajectories, the red nucleus was significantly more posterior on the post-op imaging, demonstrating that if you lose CSF, you probably have brain shift and shift of the structures you're trying to target. So post-imaging is critical. If you implant an electrode, you have to make sure you're inside ANT, and you have to tell the neurologist or the person who's going to program the patient which contacts or which contact is the best one for stimulation. So you have to do post-op imaging. It can either be a CT, and then you register to the pre-op MRI and see where it is, or if you have the option to do a post-op MRI, that's also a very good option. About between 6% and 8% of the electrodes, they will be, based on the center data, they could be outside the ANT. So another reason to check the position and let the neurologist know which contact to choose. Now, maybe the major risk of implanting the ANT is intracranial hemorrhage. They had, on that cohort of about 80 patients, 6 intracranial hemorrhages. Fortunately, none of the patients have had symptoms. They were all fine, but they found the bleedings on the post-op imagings. And I'm going to show just a few examples. Here's one of the cases where you can see subdural blood on the convexity. Another case showing a little bit of blood on the entry point. This one has a larger hematoma, interparenchymal. And for this case, you can see blood inside the ventricles. And this one, it was after the removal. The patient had to explant the device, the electrodes, and as you can see, there's some blood in that proencephalic cyst. And the same here, a little bit of blood on the left frontal lobe, just underneath the bone after removing the electrodes. So transventricular trajectories, are they that bad or are they reasonably safe? The risks of bleeding, if you go through the ventricle is higher than if you go outside the ventricle, probably due to the ependymal veins. So there are papers showing that the risk is higher, up to 10% of risk. And there are other papers showing that there's no difference if you go outside or inside the ventricle. So what about the future of ANT? Since the Santa trial, we improved our imaging. Now we can see the structures better. We improved our targeting. Now we have other options. And we started doing systematically post-op imaging confirmation of the final position. We still need to understand better the longevity of the device, of the battery, which parameters we should use. We need to understand better the networks in epilepsy of those patients. But we can also start thinking about other targets for epilepsy. And here's a review paper showing that it's been done before for multiple groups, and not just ANT, but also central median, also hippocampal DBS, STN. And I'm going to talk about all of those other targets. Now talking a little bit about the central median nucleus of the thalamus. It's located in the middle portion of the thalamus. It has connections with different areas, with the brainstem, with the cerebellum, with the cerebral cortex, and has also efferent connections with other nuclei inside the thalamus. So the network or the connections in the CM are much more complex than ANT. Another potential issue with CM-DBS is targeting. ANT, we can see it. We have landmarks to help guide us during planning. But for CM, it's not that straightforward. If you use a regular MRI, you won't be able to see CM. Just like when we're targeting VC, you would have to use probably 7 Tesla MRI for that. But we have other resources. We have atlases that we can use to guide us. We have indirect targeting. And they started developing new sequences that maybe can be useful in the future for CM targeting, just like this MP2 RAGE. But they're still not available for everyone to target. So what are the outcomes after CM-DBS? The first few studies were from the 90s, from Velasco and Fisher. They were trying to improve the seizure frequency in patients with generalized seizures. And as you can see here on the next slide, Fisher implanted 7 patients with GTCs, and he found a 50% seizure reduction in 50% of the patients, just like VNS. Velasco found better results. Yeah, he implanted 5 patients, and he found up to 80% seizure reduction. Velasco also implanted another group of 13 patients with Lennox-Gastaut, and again found a median of 80% seizure reduction. That amount of improvement was not reproduced by other groups, but those were the results he found. Another group from Valentin and collaborators, they also did CM-DBS for generalized seizures and for frontal lobe epilepsy. And for generalized seizures, they had 82% seizure reduction. And the results for frontal lobe epilepsy were not that good. They were in the range of 49, 50% seizure reduction. And that's for CM-DBS. Now, it's been used before substantia nigra, as it's been used as a target for epilepsy. And the first evidences of nigra being a good target for epilepsy, they're from the 50s. In 1952, Hayashi did a very nice study where they used different model of generalized epilepsy in rats, and they did different lesions in different parts of the brain, and they found that when you create a lesion in the nigra, you were able to suppress seizures on that specific generalized seizure model. So what are the connections of the nigra? Why nigra is a potential good target for epilepsy? So it has connections with the striatum, and then has efferent connections going to the thalamus, specifically the lateral and then anterior group of nuclei. And then in the 80s, 1982 to be more specific, this was one of those landmark papers. Yadarola and Gale, they did microinjections of GABA agonists or inhibitor of GABA transaminase on, again, a model of generalized epilepsy in the rat. And by doing that, they were able to suppress seizures in that specific model. Following that paper, that study, other different groups, they did the same, and they tried they tried different drugs for different generalized models in the rat. And as you can see, highlighted in red, most of them, or almost all of them, were able to produce or to suppress seizure in those animals. And then in the late 80s, early 90s, Sabatino did a very nice study, a very elegant study using electrical stimulation of nigra to suppress epilepsy, to suppress seizures in rats. So based on those findings in animals, in the 2000s, they started implanting for very specific cases, STN or nigra as a target to treat epilepsy. So the first one was published by Professor Benabid. It was a 5-year-old girl with drug-resistant epilepsy, and she had a focal cortical dysplasia on an area they decided was not feasible to be resected because of the possible neurological impairment. So they implanted the STN, maybe the STN with a border of nigra, and they had 80% reduction in the number of seizures. The seizures that were still happening were less severe, and there was improvement in motor and cognitive functions in that girl. Later on in 2007, the group from Freiburg, Vesper and Ostertag, they implanted STN/nigra for progressive myoclonic epilepsy. It was a male, 39-year-old. he started with intention tremor of extremities and then generalized tonic-clonic seizures. He was having worsening of cerebellar symptoms, and the motor function was deteriorating. And they tried different medications. They tried VNS. It wasn't, the outcome was not that, it was not sufficient for that patient, so they decided to implant with a DBS. And interesting, when they described the technique, how they did the same technique we use for STN DBS for Parkinson's disease. As you can see, the MCP coordinates, the MER showing thalamus, and then STN, and then NIGRA. What they did, they were just deeper, putting the contact 0, the first contact, inside NIGRA. And the outcomes were quite good, considering how severe the epilepsy was. They were able to suppress generalized tonic-clonic seizures. They had sustained seizure reduction in the intensity and the frequency. And the patient became more independent. The quality of life increased. So that can be considered a good outcome for that patient. A few years later, they published a series of 5 patients, and you can see almost all of them had some kind of improvement using STN/SNR as a target. And finally, this other group here from Switzerland, they implanted, again, NIGRA plus STN. What was interesting about this paper is that they tested different contacts, and they compared if you're stimulating just NIGRA or the border between NIGRA and STN, or just STN or above STN in zona incerta. And they found that when you stimulate NIGRA, that's when you have the best control in patients with progressive myoclonic epilepsy. So hippocampal DBS, here in the United States, it's not common to do DBS for hippocampus, just because they have RNS, so it's much more common to have hippocampal RNS than hippocampal DBS. But there's a very nice paper from Arthur. He did a prospective controlled randomized double-blind study, very nice paper, comparing either unilateral or bilateral hippocampal DBS versus control group. And the blinded period was of 6 months. He demonstrated that the procedure was safe. And as you can see, highlighted in red here, 4 patients were seizure-free in terms of focal impaired awareness seizures. And the other patients had at least 50%, 66% seizure reduction. Only 1 patient had increase in the number of seizures, demonstrating that DBS, hippocampal DBS, can be a very good option for those patients. So in summary, ANT DBS. We use ANT DBS for partial epilepsies, for focal epilepsies in humans. We have data to support that in humans. And right now, the best way to target is to do it using direct targeting, visualizing MTT. Hippocampal DBS is also indicated for partial epilepsies, and we have data to support that in humans. And again, we can see hippocampus, so we can use direct targeting. For CM-DBS, it's more appropriate for generalized epilepsy, and we have to do an atlas-based targeting or indirect targeting. And NIGRA, as a target for epilepsy, we have very robust, strong data in animals for generalized epilepsy, and we have a few case reports and 1 case series for progressive myoclonic epilepsy in humans. Thank you.
Thank you very much. Caio, it's really a very, very good presentation. An excellent presentation, elegant and accurate, made by a careful surgeon. Thank you. Now I would like to invite our moderators to questions and comments. The Professor Tatiana, please.
Thank you, Professor Paulo. Caio, I would like to congratulate you on your talk. It was very elegant, very comprehensive. And I have a lot of questions actually, but I know I don't have the time for that. So I'm gonna focus on two, I guess. Why do you think NIGRA was not more studied and not more used in humans for epilepsy? And the other one is that I know you work with connectomes and hubs and things like that. So do you think there's a possible new target for epilepsy that you can maybe think about and explore in the future?
So thank you, first of all, Tatiana. Regarding the first question, regarding NIGRA, the animal data is very, very robust for generalized epilepsy. And I think it's much more common to have in our drug-resistant epilepsy patients to have focal epilepsy or multifocal epilepsy. So I think at that point, we had so many patients with focal epilepsy or limbic epilepsy. So ANT was much more attractive than NIGRA. I think that was the reason. And regarding the second question, regarding hubs and connectomics, right now we are thinking about always gray matter, right? We think about ANT, which we're thinking about cortical stimulation with RNS or hippocampal stimulation. Maybe with connectomics, we can find important hubs within the white matter. Of course, it's very, it's not going to be easy to find or to prove that area within the white matter is going to be effective, but that's maybe in the future when we understand better the networks and how to process the data. Maybe we can find hotspots inside the network and target that using DBS or RNS, and perhaps disrupt the pathological network of those patients.
Yeah, exactly. Just because you showed the paper about the mammillothalamic fasciculus stimulating for focal patients as well. And maybe that's even a sweeter spot than the ANT itself. Yeah. So, okay, thank you so much.
Thank you, Professor Tatiana. I would like to invite now Professor Centeno. Professor Centeno, for questions and comments, please.
Yeah, I think you're muted.
The speaker, we need to turn on the
Caio,
okay.
Are you hearing now?
Yep.
It's very nice to see a guy from Ribeirão Preto like Caio in doing a very, very nice job and very nice lecture. Caio, I am very afraid about if you are leaving behind patients that the main principle of neuromodulation is to offer this kind of treatment to patients that have no options of resection. Okay?
Mm-hmm.
And then when you have a patient, for instance, that have a normal temporal epilepsy with normal hippocampus, morphological and structurally normal, and you offer, which kind of treatment do you offer? What is the first step? Recording surgeries with depth electrodes or going directly through DBS? treatment, because to these patients who are offering different results. It's not possible to compare resection with neuromodulation results. So I don't see in the majority of the papers something regarding the investigation of these patients with normal MRI, with depth electrode recording. What do you think about this? You are not leaving behind patients that could be resected and giving the opportunity to be seizure-free. And instead of this, we are offering DBS that you know that is the results are worse than resection. What do you think about this regarding selecting patients? What do you think about this?
Ricardo, I couldn't agree more with you. I totally agree with you with your statement. I think first of all, DBS can be a very good option for those patients which you don't have a possible resection to offer. Okay, and I don't think you need to investigate less those patients. I think you need to follow the same principles and do the step-by-step investigation with scalp EEG, with video EEG. If you cannot find the focus or the foci, you have to do an invasive monitoring, either by subdural grids or by depth electrodes. And then, only then, when you have all the data to say that, okay, the seizure is starting in the motor area and this patient does not want surgery at all. He will not tolerate the neurological impairment. Or if you identify you have a multifocal epilepsy, for example, you do stereo EEG and you identify 3, 4, 5 different onsets, okay? Only then you can talk about DBS for those patients, okay?
Okay, but I'm a little bit.
And you have to.
I'm a little bit afraid about the papers in DBS because sometimes I'm seeing some patients that could be investigated first before with depth electrodes instead of going directly to DBS.
Yeah.
So we need to be attentive to this approach, no?
Yeah, the problem is with the FDA criteria for ANT DBS, they're very broad.
Yeah.
Okay, so like for RNS, for example, you have to identify 1 or 2 foci.
Yeah.
For DBS, it's very broad. So, but I agree with you. We have to make sure that all the epilepsy centers are paying attention to that. They are really thoroughly investigating those patients, and then only then offering DBS. And also, when we talk to the patients about DBS, we need to explain that the chances of being seizure-free are extremely low. We know that some patients, they become seizure-free for a few months, but we cannot say the patients or promise the patients that they will be seizure-free or they have good chances of being seizure-free, because that's not the case.
Thank you. Caio, what is the possible predictors of epilepsy, of efficacy of the DBS in anterior thalamus and hippocampus DBS?
So I would say that if your hypothesis is a limbic network epilepsy, that's a very good, or that's a potential indicator that those patients might respond to DBS, either ANT or hippocampus, because based on semiology or based on the EEG findings, if you identify that's most likely the network that is abnormal, if you disrupt that network at some point, either ANT or either hippocampus, the chances are better, are higher.
And hippocampus, when you have a lesion, when you have a mesotemporal sclerosis, seems that you need a stronger voltage to give, no?
Yeah.
And even with a stronger voltage, the results are worse than normal MRI, no?
Yes, and now the question becomes why not operate on those patients? Maybe they don't want to take the risks of having a cognitive impairment. Maybe they don't want surgery at all. So we have to be very, very clear and very honest with the patients about the results, that the better chances are probably with the surgery, but if they don't want surgery, we have also a reasonable chance of seizure reduction with the DBS.
Yeah, we need to be very careful when we are talking about the results of this kind of patients, no? The selection is very important. Okay, Caio, thank you so much.
Thank you.
Very nice lecture. Nice to see
Thank you, Professor Centeno. I would like to invite now Professor Kukier, Professor Arthur Kukier. Please.
Good afternoon, everybody. Caio, so nice to see you again, even if by digital means. I'm old enough to tell you that I'm not happy with the digital meetings, but right now it's what it gets. So, and the other thing that was very nice is that Paulo asked Tatiana to speak first, you know, because the last time I tried to give her the lady first approach, I was told that this is not politically correct. So now I was officially called by the end. So it's that's perfect. What?
Sorry.
So that's fine. Just a couple of very quick comments. We have been using less and less ANT DBS, and I will explain why. I think we need to have a rationale for this, and if you use ANT DBS, you are going to be treating epilepsy that is originating from cortex that is connected to the AN it's in some way, and that means the frontal and the temporal neocortex. It's as far as you can do direct hippocampal stimulation, I don't think it makes any sense to treat temporal lobe epilepsy stimulating the anterior thalamus, because you are just using one relay forward. And then for people with temporal lobe epilepsy, we are not using ANT stimulation because we use direct hippocampal stimulation. And in US, you could use the RNS hippocampal lead. We would prefer hippocampal stimulation other than ANT for the people with temporal lobe epilepsy. And it leaves us with the frontal lobes to use ANT for the frontal lobes. But again, the ANT is connected to the mesial and the medial frontal lobe and very scarcely to the lateral frontal lobe. And to be honest, it's a small number of patients that have frontal mesial epilepsy that do not have a lesion there and will be very good candidates. But anyway, we still use ANT for this kind of patients. I was very interested when you mentioned the substantia nigra stimulation because, you know, at some point I asked Halim if I could have a look on his, because they have hundreds of PD patients treated with DBS of the STN. And I asked him, hey, listen, can I go to Grenoble and have a look on the patients who have both Parkinson's disease and epilepsy? Because then we can have an idea what's going on with them, you know, because they have these two diseases and the same target and etc. And the answer was, well, you can visit, there is no problem, but we have only 3 patients with Parkinson's disease and epilepsy. And this is likely because there is an antagonism from a pathophysiological point of view between epilepsy and Parkinson's disease. Namely that when you get worse of one, you get better to the other. So when you improve from epilepsy, you get worse from Parkinson's disease and vice versa. And this was noted by the end of the 19th century by the French neurologists. And this is, it's something that we do. So I'm not sure if, maybe you could comment on that. I'm not sure if using substantia nigra you get the same result. Maybe you can actually do exactly the contrary in the nigra. Instead of blocking the nucleus, you can maybe you can stimulate with lower frequency and stimulate the nuclei. We were all excited about carrying Gale's Arias Tempestas and Nigris triethyl for control epilepsy system, but it's likely that you have to use different paradigms if you're planning to use the substantia nigra. The other comment is on central median targeting. I fully agree with you when you say that direct imaging-based target is better. This is very clear from the Sante study. If you really look on the patients on the Sante study, they have electrodes everywhere, but they didn't use image targeting. And the central median, the study you mentioned from Australia, which is a very good one, is part of a control study on the use of central median DBS on Lennox-Gastaut patients that's going on in Australia. But if you look into our targeting using electrophysiological intraoperative monitoring, for instance, and this is something that has just been accepted in Seizure, is going to be published in Seizure very soon. The target that we arrived there by using intraop neurophysiology and proportional targeting is exactly the same that they get by imaging, except for the anterior-posterior position. Our anterior-posterior position is much nearer to the posterior commissure than theirs. They have the central median like 5 or 6 millimeters in front of the posterior commissure, and our central median is almost by the position of the posterior commissure. So maybe you could also comment on this, where do you think the central median is? And regarding hippocampal stimulation, as far as the published results, it appears that continuous direct stimulation of hippocampus has superior results compared to ANT and RNS. It's of course very difficult to compare the techniques because the studies are very heterogeneous in terms of it's very difficult to compare them one to each other. But as far as the published RCTs, direct stimulation of the hippocampus continuous is at this point better. There is, of course, as you mentioned and you were discussing, a discussion if invasive recording would be mandatory in all cases that would be submitted to DBS. We don't think so. And as a matter of fact, I would say that at least 50% of the patients that are now implanted with DBS for epilepsy do not undergo SEG. But there are definitely some patient population that they don't need SEG. For instance, patients with bilateral temporal onset, they don't need if you're not planning to operate, you don't need SEG because you're not planning any resection. And as you mentioned, if you have temporal lobe dominant normal MRI patients where you're not going to be resecting the hippocampus anyway because there is a huge memory risk, so you don't need SEG either. It is ongoing, but maybe you could comment on the need of SEG for DBS for epilepsy. Again, thank you so much and congratulations for the nice, extremely great overview. And have fun there.
Oh, thank you, Artur. Thank you. Thank you very much for the comments. I'm going to start with the CM. Here we don't have much experience with CM. All of our cases are ANT. But we are very imaging heavy here. So we've been trying to develop imaging methods to help on localize the CM and trying to use tractography to connect the connection between different cortical areas and use going through the thalamus through CM. So far, we didn't find anything useful for that. So there are some, as I showed, one of the sequences MP2 RAGE, they developed like recently, might be useful, but we did not use the same parameters here yet. We're going to try that in the future. But one thing we are trying is to use, to develop a tractography method to help localize CM. One of the slides I showed that there are multiple connections. So basically CM is connected to almost, let's say, almost everywhere. So it's going to be very hard to find the same connections, just like we do for VC or for VIM using tractography. And we don't use MER for that, for epilepsy either. So I wouldn't be able to say that if we use here, it's going to help us or not, because we don't have experience on that. But I agree with you that neurophysiological data always an important and a very powerful tool, either for if you want to say for Parkinson's disease or for epilepsy, that might be helpful. And regarding the SEG question, if we should use always stereo EEG, I think we should use stereo EEG when we don't know exactly where the seizure is starting. For example, you mentioned a patient with dominant temporal lobe epilepsy. Of course, if we already know that that's where the seizure is starting, we don't need to do stereo. But if we're not sure which side is causing the seizures, if our hypothesis is bilateral, then we sometimes try to make sure that's just exactly the left side that is causing the seizures before offering other options, just like RNS. And one question that I have for you. So if you had the two options in Brazil, RNS and DBS, how would you decide between using one or the other for hippocampal DBS if you had the two options? Yeah, I think you're muted.
Your microphone, Arthur.
Yeah.
Sorry about that. I think I would have a theoretical and a practical approach for your question. Mm-hmm. From a theoretical point of view, I would say that closed loop stimulation is the future of neuromodulation, meaning that we will need to have some type of sensing and response, and that closed loop stimulation makes lots of sense, and it will be the way to go. This is the theoretical answer. The practical answer is, so far, continuous stimulation is better than RNS findings in patients with temporal lobe epilepsy. And this is because we likely don't know exactly the right paradigms for stimulation using the RNS system. So the problem is not the concept of the RNS system, because the concept is great and the science behind this is great. And what we learn about epilepsy, about all these chronic long years of recordings of this patient is also great. But the fact is that the paradigms are not yet developed and the sensing mechanisms are not yet so good. Many times the sensing electrodes or contacts are far from the stimulating electrodes and things like that. And even the charge density that you can deliver from the device is quite low. I would say that if I had both at this point in Brazil, and we hope we are going to have it, I think I would, at this point, use hippocampal stimulation for temporal lobe patients continuous. But hopefully in 20 years, we have better results of responsive neurostimulation. You know, if you look into the chart density received by the patients using RNS, it's very small. It will be like 15 minutes of stimulation per day. It's really very small. And this is why, I think this is partly why they don't have many seizure-free patients. In our double-blind control study, we have 50% of seizure-free patients. And in our long-term follow-up, we have 46 seizure-free patients, percent seizure-free patients. So it's very stable. The response is very stable. It is much higher than the RNS. Again, for instance, if you have foci outside the temporal lobe, I would use RNS-like stimulation in those patients, but not exactly with a tubular context, but more like with kind of grids or strips or things like that. Well, in summary, from a practical point of view, you need to do one thing today, but you hope that for the future you're going to be using more and more responsive neurostimulation.
Yeah, one of our strategies here with RNS, when we identify that the patient has bilateral hippocampal seizures, bilateral hippocampal onsets, we offer RNS not just for treatment or reduction of seizures, but also for long-term chronic monitoring. So after 1 year or 2 years, we analyze the data. If the patient has significantly more seizures on one side, the ratio, let's say 95, 98% on one side, and just random seizures on the other side, and if the side that is more active is the non-dominant side, then we offer the option to do a temporal lobectomy and still keep the electrode on the other side.
You know, you're touching a very, very important thing, because right now when we do invasive recordings, we based our decisions on what we get at 1 week of recording with invasive electrodes, with medications withdrawal, and etc. And this is, you know, this is what we can do, but this is not good, you know, because you have to. I don't think we are far from the moment. I think you're definitely going to see it, but I think I still going to see it. You know, the age in where what we are going to be doing is we are going to be implanting the patients with depth electrodes and chronically and send them home. And then they will stay with the electrodes for 2 or 3 months or 6 months at home. And then we will get lots of information about these patients, and we can calmly make our decisions regarding what to do with this patient. So chronic electrocorticography is likely to be available for us very soon. And the major problem right now with the RNS system, for instance, is that their data capability is very low. They cannot keep recording. When they say that they record for years, that's true, but it's not 24-hour recordings. It's, you know, it's a very limited capability of data management. And the other problem is that the thing has to be implanted in the skull. And this is because the noise to radio signal of their amplifier is very bad. But as soon as we solve the data capability thing, you know, and the radio to noise amplifiers things, and you could implant in a more comfortable way, I really not, I'm pretty agreed with you, you know, we are not far from the time where you're just, you know, we are implant the patients, send them to the ICU for a day and for a regular room to another day, and that home, and then, you know, back a couple of months, and we'll see.
Yeah.
Okay. Thank you very much, Professor Cookit. I would like to invite now Professor Almeida, Professor Antonio Almeida.
Hi, Caio. It's a very, very interesting presentation. I really enjoy it. What I would like to, just a simple question, is about trajectory to ANS. What's your first choice today and the second, and how do you see? Because you showed several approaches, but you didn't say, wow, I usually do this. What's your preference?
So my personal preference is the transventricular through the coronal suture approach. That's my number one option. If I have any issues with the blood vessels or like that case I mentioned with the titanium mesh, then I go the posterior approach. I try with our patients, I always like to exercise the extra ventricular trajectories but I'm rarely happy with the position of the contacts. So if you want to, like we do for hippocampus, we do the posterior approach and we cannulate the hippocampus, right? If you try to do that for ANT, you have to go very close to the midline and through the ventricle. And that's when you skive the thalamus. And the final position it's sometimes good, but not the best one. So that's why I like to go from the anterior approach and transventricular.
Okay, that's my question.
Okay, thank you, Professor Almeida. Today we have a special participation for Professor Hélio Machado. Professor Hélio, Professor Machado, please.
Thank you, Paulo. Thank you very much. It's so nice to see Caio and to see in this panel, we have three from Ribeirão Preto, Ricardo Centeno, Caio, and myself. So nice to see that and to see how far Caio have gone. Congratulations for your talk. It's excellent, fantastic talk. The only thing I have to say is you must go ahead and follow your destiny. This is great. I just want to mention, as you know, my field is pediatric epilepsy surgery. And I was surprised to see that some of the people that you presented here have done surgery or kinds of DBS in children. Velasco, for instance, Valentin, and Benabid. Benabid is an icon in neurosurgery, a very talented guy, and he did surgery in very small children. What is the reason? We have lots of patients that we can't do anything with the resective surgery. What is the reason why this is not applied to the pediatric patients? Do you have any reason for that?
So first of all, it's a pleasure to see you again, Professor. Professor Hélio Machado is one of the people responsible for me being here today. I really enjoy our training when I was a resident, and thank you for all the everything you taught me over those years, and I'm still learning from you every day. So I think so. They started the when it was approved by the FDA, the criteria was very clear regarding the age. So 18 to 65. So that's why since the stunted trial, we didn't see widespread use for DBS in children. I think that's one of the reasons here. And the second reason, I think it's the type of epilepsy in children. They're very, it's a different population. So you have, in adults, you have, in those patients that undergo ANT, usually they have multifocal, limbic or frontotemporal epilepsies that are not suitable for resection. In children, you have different types of epilepsy, and sometimes since they are more severe and they have a better plasticity, the surgeons are more aggressive in terms of resection. So a similar epilepsy with a similar imaging finding, maybe with the children, the surgeons consider to be more aggressive because they believe in the better recovery than the adults. That's one of the explanations I think about, but there might be others that I'm not aware of.
Yeah, thank you. Thank you very much. Thank you, Paulo.
Thank you, Hélio. Professor Machado, thank you very much. During the discussion, various questions from the audience were answered, but We have some questions from audience, very interesting. One is for Professor Cuquiert. Professor Cuquiert, is about one important paper you published in the term is insertional effect. Our colleague would like your comments about insertional effect and DBS and anterior nuclear thalamus implantation. Thank you.
Caio, would you like to answer to that too, or?
Oh, no, please go ahead.
Insertional effects are really common in both hippocampus DBS and in centromedian DBS. In fact, it was very clearly demonstrated in a Sante study too, because they have 3 months of blinded phase in the study, but the insertional effect complicated their analysis because they were, the results were significant only in the 3rd month of the blinded phase. And this is likely related to an insertional effect. So insertional effects are there. We don't know exactly what they mean, but they are likely related to microlesions. In terms of patient care, I think knowing that there is an insertional effect, our suggestion is that before start programming the patients, you allow them to get back to what they refer as their baseline seizure frequency, because otherwise you're not going to know what you're doing, especially if you're planning control studies. You cannot allow patients with insertional effect to contaminate the database. And that's why we suggest that the double-blind phases should be larger, as it was in our hippocampal stimulation for 6 months instead of 3 months in the NeuroPace study and in the Sante study. This is one thing. And the second thing is, if you're planning a control study, you should allow the patients 2 months for recovery before starting your protocol, because then you allow them to recover from surgery and from the insertional effect that usually lasts less than a month or 2. So you have to take this into consideration. Otherwise, you don't know what you're doing. We do have patients, they are not frequent, but they are there, and they are running around the office every time, that they are completely seizure-free after hippocampal DBS without stimulation. So this means that the microlesion was enough to simply turn them seizure-free. But we know this because we allowed them to start seizing again, because if we didn't do that, we would be stimulating them and think that what we are doing was related to stimulation. This is not true. Again, they're not common. It's like 3 to 4% of the patients, but we need to study this patient population who have insertional effects, and maybe we can get a more clear insight on the pathophysiology. If you can know the positive predictor effect by the biomarker of this, we can change our way of thinking. On the other hand, we do have patients who became seizure-free after centromedian DBS, which is a whole different thing, because you cannot understand very clearly why, if you put a centromedian DBS and the patient just became seizure-free, you are not touching the cortex, you are not creating a huge lesion in the thalamus, and the patients are seizure-free. We have at least 3 patients with centromedian DBS. They just never seize again after inserting the electrodes in the centromedian. And the only thing that they have in common is that they have in the thalamus, in the preoperative scan, what we call the UBOs, the unidentified, like the UFOs, it's unidentified bright objects in the thalamus. These are, totally non-specific findings on MRI, and we don't know why they are there, and they are there in many patients, not only on these patients, but this is the only common thing on these patients. So insertional effect is there. It's important from the programming perspective and is very important if you're planning control studies.
Thank you, Professor Arthur.
Yeah, let me just make one comment on that.
Of course.
Thinking about research now, not like a clinical approach, but if we could, on those patients, do the hubness or the connectivity analysis that Tatiana was mentioning, and if we could demonstrate that the most important hub or the most connective voxels or area inside the brain was were overlapping with the area of stimulation, then we could have reasons to move forward or to support moving forward with the connectivity to improve targeting for DBS.
If you like, I can send you the patients to Jefferson's and you can go ahead.
Okay.
Thank you. Our time is finishing, but I would like to do one more question from audience. Caio, Professor Matias, please. If the question, if you have a protocol to define which patients go to VNS and which for thalamic DBS, okay, Justice, if you have any protocol to define, if the patient began with go to VNS or to thalamic DBS, CM or NIT?
So talking about adults, our approach in adults.
Yes.
Okay. So the population is very similar. Multifocal epilepsy, patients that we have investigated, and we don't think they're good candidates for resection. We can offer both. Our Jefferson, the group here, they prefer DBS. They're not very satisfied with the results of VNS. So historically, they're not very aggressive on VNS indications. So we offer the options for both options for the patients, explaining the seizure reduction rate of both. We give them the options, and we explain about MRI, post-op MRI options, and if in the future they need to remove the device for some reason, what are the possible consequences or risks of that removal. So in my mind, to make the long story short, I would favor, if we have both are good options for that specific patient, I would offer both, explaining the pros and cons of each, but I would favor myself DBS, which I think can be almost as less invasive as a VNS in terms of surgical risk.
If the VNS doesn't work, you move to DBS?
That's another option, yes. If they prefer VNS, they try, it doesn't work, then we can also offer, we can always offer DBS later on.
What's your opinion, Professor, about direct MTT stimulation?
I think when we are targeting ANT, we are stimulating at some level MTT. We're not just stimulating ANT. It's like when we stimulate STN for Parkinson's, for example. It's not just STN. You are stimulating the white fibers around STN. So I think we are stimulating MTT when we target ANT, or vice versa.
What's your opinion about the posteromedial hypothalamus nucleus stimulation or multifocal epilepsy?
With that target, I have zero experience, so I can't say if that would be a good option or not.
In the programming patients, why only the amplitude of the stimulation is modified, and our audience question, and the rest of electrical parameters remain steady?
We don't understand the role of frequency, low frequency, high frequency, 30, 40, or 180, 130. We don't understand that. We understand pretty well increasing the amplitude, what that will cause. So I think that's why we play only with that parameter. And that was like the protocol, the recipe on the Santa trial. So they keep using until today. But we can, if we want to play with pulse width, we can. There's no contraindication with that.
Okay, I would like to open the microphone to the moderators if have another question to finish our meeting. Professors, please.
I'd just like to comment on the parameters, because I think it's actually a very important. Can I go ahead, or
it's okay, Professor Coquet. After you, Professor Tatiana. After you.
I cannot give the lady first again, right?
Well, I tried.
Okay, so just a short comment on the parameters, because I think it's a really important issue, and the problem is let's start with frequency. To play with frequency, it's one hand very easy and the other hand very difficult. For instance, if you want to play with frequency with Medtronic electrodes, they don't go over too much, 250 maximum. So you're not going to be able to play with more than that. And if you are planning to really block axonal activity, we are talking about 2000 hertz or 3000 hertz stimulation. It's really high frequency. So I'm not sure if playing with 130 or 250 would make any difference. I think we need to play with very high frequency stimulation if you are looking into some difference. And for this, we need another type of apparatus. It's available for spinal cord stimulation, but not yet for brain stimulation. And the other option would be to play with low frequency stimulation, because we know that below 60, there is a difference. So you can use low versus like 10 versus somewhat high, like 130 or 250, but you cannot compare likely not be able to compare 130 with 250, because this is going to be the same way. This being said, there has been, unfortunately, I would say, no direct comparison of modifying frequencies and duty cycles in neuromodulation. From my perspective, for instance, the people from the Sante study, they lost a very good opportunity to do that, because the Sante study used cycling stimulation, like some moments on, some moments off. So this is cycling stimulation. This is what they used. They had a wonderful opportunity to turn all these patients into continuous stimulation and look if they are going to be doing better or worse, or they are going to be unaltered. So this means that playing with the other parameters like duration and seizure and frequency and etc., you have some hardware problems, but then we can deal with that in the future. But then we really need direct comparison, head-to-head comparisons of these stimuli parameters. Otherwise, it's a nonsense to start. Well, it's not a nonsense, but it's just you just keep trying things. You're not going nowhere in terms of knowledge of the disease or the treatment.
Trying neuro methodology. Dr. Tatiana, please, finish our meeting. Please.
And my question was exactly about that. If you have any protocol when the patients don't respond initially, so you change the amplitude, but how far you go, how high you go, and for how long you test that amplitude till you decide he was still not responding, and what is your next step?
Yeah, that's the problem with DBS for epilepsy. With essential tremor, for example, you can change the parameters and check on the patient the result in the same visit. For epilepsy, you don't know. So how much you increase 0.5 volts, you increase like 1 volt. So the protocol is to, there's no fixed protocol. So usually they do increments of 0.5 volts, and they have to watch how the patient is going to respond over time. So that's a very, very long process. And since they're being programmed by the neurologists, they also, if they could help with the medication doses and side effects. So they do both. They change the parameters and also the stimulation parameters and also the medication.
And for how long they generally wait till they decide the patient, they have to increase again?
Yeah, usually 2 or 3 months.
Okay. And have you tried to do continuous stimulation?
No.
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 Okay.
I believe Professor Centeno wants to talk. It's
Hi,
true.
Caio, it's a very nice opportunity to talk about DBS, because DBS is in the frontier of knowledge. To have good results for movement disorders, but at the same time, the epilepsy not have so good results as movement disorders. And since there is a range for different pathologies from the results of this treatment. And it's very nice because, as I said before, about SEG, it's not because I am against this therapy, but we need to be very alert about what we are going to do in the future about the cost benefit of this treatment, because here in Brazil, you see, you know that is completely different than in US. So it's very nice to learn about your experience in the US, but we have a long way with epilepsy surgery and DBS. We don't know, we need to know more about this. Actually, at this time, you have only two randomized controlled trials with a big number of patients, one with an ANT and another one with hippocampus. And then we have a lot of open label studies that you don't know exactly what is going on. So at this time, there is more question than answers. Yeah.
Yeah.
So it was very nice to discuss with you about this team, and thank you so much.
Thank you.
Thank you. Thank you, everybody. It was an excellent day, elegant. I would like to thank you all. And now I would like to call our president, Dr. Antonio Almeida. Antonio?
Okay, I would like to thank you, Caio, for sharing your experience. It was, as I said, a great lecture. All the panelists really did very well. I think the comments and the questions were really good. So I thank you all. And let's finish this. And next week we'll have another session. So thank you and bye.
Best wish to everybody and take care.
All right.
See you.
Thank you.
Bye, Caio.
Bye, Caio. Thank you. Bye, everybody.
Bye, everybody.